chronic infection based on the pathophysiology and the production of bacterial biofilm that is a glue product by the pathogen that could be a challenge to treat. That's why in patients with acute infection, we are doing a DARE, debridement, antibiotics, and implant retention, so a conservative approach. And that's why during chronic infection, when you have a lot of biofilm, you need to perform prosthesis exchange, 1 stage or 2 stage, followed by antibiotics. And the prosthesis exchange is here to cure mechanical problems, but also to eradicate the biofilm. In fact, sometimes it is discussed to perform during chronic infection a DARE. Why it is not so frequent to do? Because you have a lot of biofilm, and if you are doing a DARE, conservative approach, during a patient with chronic infection, as you can see, when you increase the time from prosthesis implantation to DARE, the risk of failure is increasing drastically because of the biofilm and the chronic infection that is still in place. So if you would like to use a conservative approach, so a DARE, in patients with chronic infection, it is possible, especially in patients without loosening, without mechanical problem, but we need to use suppressive antimicrobial therapy called SAT, because it is not possible to cure the patient, but we are using prolonged antimicrobial therapy to avoid replication of the bacteria and to control the disease. So this is SAT, suppressive antimicrobial therapy, well described in the Spanish guidelines, especially for patients unsuitable for implant removal, especially due to baseline condition, poor functional outcome is prosthesis exchange is performed. So the patient needs to continue antibiotics lifelong or for the life of the prosthesis that is treated. And 10 years ago, in the American guidelines, there is a topic on suppressive antimicrobial therapy. And as you can see, most of the antibiotics that are used are oral drugs, beta-lactam, clindamycin, cotrimoxazole, or tetracycline. But finally, suppressive antimicrobial therapy is not perfect, but because, as you can see here, suppressive antimicrobial therapy does not always prevent a failure, especially because some patients have no surgery at all, no DARE, so no reduction of the inoculum, or the patient could have no primary antimicrobial therapy. They are directly use simple oral treatment that could impact the success of suppressive antimicrobial therapy. So we need to imagine what could be the medical innovative strategies that could increase the rate of success of suppressive antimicrobial therapy, and so to keep the function. So we are working with Sebastian in Referral Center for the Management of Complex Bone and Joint Infection in the Lyon University Hospitals. As you can see, thanks to our expertise, the patients are coming from so far in our hospital. And the concept is to use sometimes no prosthesis exchange, but a conservative approach in particular patients. And my job is to find additional intervention to improve the infection control of these patients. And we have, for instance, some subcutaneous suppressive antimicrobial treatment, especially for patients infected with multi-resistant pathogen for whom there is no oral option. It could be discussed for some patients with big implants, very difficult to exchange. And if there is no loosening, even if the pathogen could be not susceptible to oral option, we developed OSCAT, that is outpatient subcutaneous antimicrobial therapy. It is the use of intravenous antibiotics that we could give to the patient subcutaneously with a very small needle. We published some paper on that field, and we are using particular drugs that have long half-life, such as ceftriaxone, ertapenem, ceftazidime, or cefepime. And we are using pharmacokinetic, pharmacodynamic dosage individualization in such patients. You can see here, this is a blood measurement of the antibiotics in a patient receiving ertapenem intravenously. We are checking the blood results, and my colleagues, pharmacologist, is doing modelization to see what would be the exposition to the antibiotic in patient receiving the drug, only 1 gram on Monday, 1 gram on Wednesday, and 1 gram on Friday, 2 gram on Friday, sorry. And depending on the MIC of the pathogen, it is possible to have clinical control with this kind of management and injection only 3 times in a week. So very nice development. Other potential intervention that we could do is to perform local antibiotics in patients with chronic infection for whom we would like to not exchange the prosthesis due to risk of complication. So you mentioned that it is possible to use antibiotics locally. For us, we are not using tubes to inject local antibiotics because there is a risk of superinfection, and maybe the future is to use local antibiotics with carrier that could be hydrogel, or that could be antibiotic-loaded calcium sulfate beads that are bone substitute, frequently used for osteomyelitis, but we could use potentially this kind of beads loaded with antibiotics. For instance, it's possible to load these beads with vancomycin and gentamicin at the time of surgery. So it is carrier of antibiotics to have the ability to deliver antibiotic during time, during more than 2 weeks, as you can see. And this bone substitute has the ability to liquefy during time, but there is a little risk of discharge. So caution in patients for whom wound closure could be difficult, and we have to have more clinical data in this field. The final intervention that we would like to develop is the bacteriophages. Very important topic here to increase the clinical success of conservative approach in patients with chronic infection. So what is a phages? It is a virus, specific virus that infects bacteria. And in fact, bacteria have also their pandemia. Because when you are sampling in the ocean in different depths, the water in the ocean, you can find a lot of bacteria, and close to the bacteria, you have some phages. But the phage could give advantage to bacteria, virulence factor, antimicrobial resistance, or resistant to immune function. But some phages could be virulent for the bacteria, could replicate inside, produce a lysine that disrupts the cell wall of the bacteria with autoamplification process of the phages that infect the bacteria. And this autoamplification process could be very interesting to control the bacteria. And finally, phages have 2 ways of action. They limit the bacterial replication, very important. And most of time, they have antibiofilm effect that is synergistic with antibiotics, that is crucial in patients with implant-associated infection. That's why we have a dedicated program to develop phage therapy in Lyon, called Phage in Lyon Clinic, dedicated to phage therapy as defined by the WHO as non-traditional antibacterials. We are doing that in close relationship with the French Health Authority. We integrated the phage therapy center in our referral center for complex pulmonary infection for patients in dead-end clinical situation or at high risk of significant loss of function. We are using pharmaceutical grade only, so we have to work with the healthcare authority. These phages fulfill a list of quality controls. We need to perform before phage application phagogram. It's like antibiogram. It's to be sure that the phage you are using has the ability to infect the bacteria and have antibacterial effect. We are using combination of phages in cocktail, and it is very complex to set up because we need to have a hospital pharmacist who mix and prepare the cocktail of phages under sterile condition at the time of injection just before surgery. So it's a huge organization that we need to have if you want to develop phages. So we published a lot of paper about the use of phages in patients with bone and joint infection, and particularly prosthetic joint infection. We published some case reports, some case series. We published also phages with a carrier such as hydrogel. We are using phages for multi-drug resistant Pseudomonas aeruginosa infection. And for me, the most important indication could be patients with chronic prosthetic hip infection, for whom the surgeon think that revision could be associated with loss of function. And at this time, for this patient, we are using a conservative approach, such as open or arthroscopic DARE, and we're using phages during DARE. So we published this little case series in patients with relapsing Staph aureus prosthetic knee infection, for whom we set up a protocol called PhagoDARE, is the use of phage during DARE. So this is typical patients that we have, elderly patients with chronic prosthetic left knee infection. The patient already experienced chronic Staph aureus infection. He already had DARE and suppressive treatment, and we have a relapse, very complex clinical and orthopedic situation. And for this kind of patient, we are doing another DARE because revision is very complex. And we are thinking about different exposition with subsequent injections under sonography that we could have to try to control the disease, especially in case of relapse. And we submitted to the ECCMID an abstract that has been selected as top-rated abstract next month in Copenhagen. So this is typical patient for whom DARE has been done. DARE facilitates the reduction of the inocula, and then the surgeon closes the joint. And there, as you can see in this liquid, we have billions of viral particles that have the ability to infect the Staph aureus strain of the patient. So we hope to have antibiofilm effect, and we hope to have effect on the bacterial strain. So we are doing one-shot injection during DARE. And after that, remember that the infection was uncontrolled in this patient despite antibiotics. And after that, it was possible for the patient to walk, no pain, and no clinical signs of infection. So the phages help here to control the infection. But and the outcome was very nice. At 2 years, we published this case in this paper. But finally, during extended follow-up, the patient experienced a relapse under suppressive antimicrobial therapy with the same Staph aureus strain that was still susceptible to phages. And we set up a particular salvage intervention that was no surgery at all, but injections of active phages with a 1 week interval. Again, no tubes to avoid superinfection. And we injected in this patient dedicated active phages under sonography in the abscess that was in communication with the joint. As you can see here, I simply added doxycycline, 1 pill orally as suppressive treatment. And we had this kind of effect, again, without surgery, perfect control of the disease with the phages and the suppressive antimicrobial therapy. And again, the infection control process was nice during 2 years following this intervention. After that, the patient died from other problems, cardiac problems, without any pain, without any clinical signs of infection. So a very nice option to control the disease in elderly patients. So we set up a randomized clinical trial in France and Spain called PhagoDARE 1 with a company that is provided the phages in patients with chronic prosthetic joint infection requiring DARE plus suppressive antibiotics. It is a randomized clinical trial, the patient during the DARE receiving phages or placebo. And we set up also the salvage procedure with injections during sonography in patients for both arms during the follow-up. We have also set up phage therapy, in particular patients with contraindicated to open DARE. So you know that arthroscopy has no place at all for the treatment of prosthetic infection. But in fact, it could be useful because it is a minimally invasive procedure and we could put the phages during surgery. You have no risk of superinfection because it is not open surgery and it is nice for the patient. We publish this case and it could be also an option for the future. So we set up phage therapy center. We treated 54 patients at this time, mainly with the phages from a French company called Ferricides, but we are using also phages from different origin, and we can set up a public production of phages. Most of the patients had prosthetic joint infection. This is the most interesting indication, and it opened the door to treat other indication. And we helped some colleagues in Sweden, but also in Switzerland, to treat some patients with phages. And as you can see, half of the patients had multi-drug resistant pathogen. And we have phages only against Staph aureus and against Pseudomonas aeruginosa. So it's one of the limitations. And we developed also another way of treatment with lysins, that is only the enzyme of phages that is active on Staph epi. And we will have clinical trials in the field. Thanks to this experience, the French Health Ministry gave us the ability to centralize the request for phage therapy in patients with complex pulmonary infection in France. So we would like to increase our experience in the field and to perform clinical trials. So conservative approach and the DARE could be proposed to patients with chronic prosthetic joint infection without clinically significant loosening, especially for elderly patients or for patients with past revision or patients with rejection prosthesis without loosening. Multidisciplinary management with infectious disease physician is crucial to imagine to manage this patient. These patients have indication of suppressive antimicrobial therapy to control the disease. And I think there is a huge place to increase the success of SAT by subcutaneous suppressive treatment, by the use of local antibiotics with carrier, and also with the use of bacteriophages. And the future is fantastic because we will have a lot of clinical trials in the field. I would like to acknowledge all my colleagues in Lyon, especially my colleagues in the infectious disease building that you can see here. And don't hesitate to check our website, to follow up on social media. And thank you so much for your attention.
Thank you, Professor Ferry. Thank you very much for your great presentation. And congratulations for your huge successful in on phage therapy on bone joint infection.